Thank you very much for that kind introduction. I stand before you with a tremendous sense of awe, a tremendous sense of privilege for the work that each of you are doing. And these next several days are transforming the delivery of health care as we go deeper into the 21st century, because the status quo is no longer adequate. Dr. LaRusso called me on Friday and asked if I'd be able to participate. And Nick, I want to thank you for this gift to be here, because there's an energy and there's a karma that's absolutely mind-boggling. Just a little word about myself on a personal note. I grew up in Newark, New Jersey, which is the home of Whitney Houston, Marvelous Marvin Hagler, Dionne Warwick, Shaquille O'Neal, and me. Went to the University of Michigan, New York Medical College, National Cancer Institute, and came to Mayo 36 winters ago, and it's been a wonderful privilege. As John mentioned, I'm board certified in hospice medicine and palliative care, and I think to read Mr. Wolf's commentary is important to put into perspective some really crucial end-of-life issues. Many times when we speak in public, we're asked to comment about any relationships with industry. And I should share with you, I use no performance-enhancing drugs. I've never tested positive for steroids. Is the mic on? Mic is okay. Nick, I'm dying up here. Okay. So let's talk about one of the elephants in the room. I need to share with you that I came from a somewhat eclectic background, and that my father made his living at racetracks. He was a bookmaker, a professional handicapper, and a jockey's agent. And one of the things I learned from my father is that there's no such thing as luck. We make our luck. Our being here has nothing to do with a roll of the dice. It has nothing to do with a spin of the roulette wheel. Now let me just share with you a moment about a horse. This is the Kentucky Derby of a couple of years ago. And this is a horse called Giacomo. With 3/16 of a mile to go, hopelessly blocked behind a wall of horses with no probability of winning. About 20 minutes later in the winner's circle, the most surprised person on the planet was the horse. Now, the racing experts said that this was an act of divine intervention. The horse had a greater chance of getting hit with lightning. But growing up, the only newspaper we ever read was the Daily Racing Form. The New York Times, forget it. Wall Street Journal, no. But the Racing Form had all information about horses. And for people who studied the form, they could have predicted that this horse was ready to fire. So the point of it is, we make our luck. Life is not a roll of the dice. Now, this is one of the elephants in the living room that we're going to be addressing. But there's a second elephant that we're going to be talking about in a few minutes. So let's fade this elephant into the background. And let's go back to Rome 1960, the Summer Olympics. The longest race in the Olympics is the marathon, 26 miles, 385 yards. And the race was done by an obscure Ethiopian runner called Abebe Bikila. And for those of you who have friends in Ethiopia, you mention that name. He's a sacred, iconic individual who passed away several years ago. And he ran the race barefoot, 26 miles with no shoes. And interestingly, halfway through the race, he was mauled by a dog, and yet he finished the race. Now, one of the shortest, there he is here, one of the shortest races is the 110-meter high hurdles. At the Olympic trials, this is Mr. Lee Calhoun, who won the trial to get to the Olympics. But the man we want to talk about is Mr. Willie May. Mr. Willie May. When the final race was won in Rome, Willie May came in second by 1/100th of a second. This was the closest race ever in Olympic history. But let me tell you the rest of the story. This is St. Mary's Hospital, and I was on our palliative medicine service a couple of months ago, and I might add, I'm on that service now, and here we have 40 patients whose average survival is about 72 hours. So it gives us a perspective of medical technology, what is possible, but also some of the ethical issues that it raises. So what about Willie May? Dr. Keith Mansell, one of my colleagues, and I saw Mr. May, and he was referred to Mayo Clinic from Illinois to receive a mechanical heart. This is called a left ventricular assist device. LVAD is the term that's commonly used. And we are the only institution on the planet where the palliative care people, the cardiac surgeons, and the cardiologists see these patients together and explain options and alternatives. So we're sitting at the bedside and explain to Mr. May and his family what this procedure would be like. And at the end of our dialogue, we said to him, Mr. May, do you have any questions? Do you have any concerns? He said, yes. Would you call my pastor? So he gave me his cell phone, speed dial Pastor Jimmy Thorne out of Chicago. And on a speakerphone, we reviewed with the pastor the issues that we share with the patient. And at the end of the discussion, the pastor said, I'm going to pray for each of you. Wow. Tears kind of welled up on the entire team because the pastor was a kind of translator for the patient, interpreting and rephrasing our words. Now, this is an intensive care unit where most of us will spend the final 10 days of our life. Most of us will spend the last week of our life in this place. And one of the challenges is that we will be seen, like Mr. May was seen, by an armada of technical specialists, such as the cardiologist, such as the cardiac surgeon, such as the pulmonologist or the lung people. We also have colleagues representing kidney work, nephrologists, infectious disease, the neurologist, the gastroenterologist. But who's missing from this? This person here. We're showing our age. Does anybody recognize him? This is Marcus Welby, MD. He was the quarterback. He was the travel agent that would interpret the technical jargon for us. But he doesn't exist anymore. And this is one of the issues that Mr. Wolf raises. This is Pastor Jimmy Thorne, whose office I called this morning. It was clear after 3 months in the hospital that Mr. May was not doing well. His kidneys were not working, he had serious infections, and all of the experts sat down with the patient who was in a coma and his family and his 2 daughters and explained the limitations of technology. This was at about 10 o'clock in the morning. We get on the phone at the family's request and call Pastor Jimmy Thorne. He was in a barber shop in Chicago, and you know what he said? I'm on my way. 6 hours later, he comes to Rochester and works with the family and us to de-escalate care. So this was an individual who acted as a translator to make sense out of the technical chaos that the family was struggling with. Now, there's a second elephant in the room that we never talk about, and that elephant is the elephant of wills and trusts and estates. I was at a meeting of the American Academy of Palliative Medicine in Louisville in July, and the speaker asked for a show of hands. Now, this is people like us doing this stuff. How many of us have wills and trusts, and maybe 20% of the hands went up? Because every day what I see is what happens when people don't take care of financial affairs. Now, I'm no MBA, but I've seen a number of disasters where you have blended families and split families and all sorts of relationships, and if a will is not done properly, generations will be separated trying to decide who gets the farm, who gets the golf clubs, who gets the combine. The other thing I would share with you, that every one of us should be able to share with anybody who is our proxy, who speaks for us if we are unable to speak, and what level of aggressiveness do we want if, Lord forbid, we're in one of these units. Most people don't think about this until the 11th hour. So let's get rid of that elephant, and let's talk about what we can learn from each other. Okay, number one, there needs to be a medical quarterback. And I think that's where the palliative care community, and tomorrow you're going to hear from Dr. Corey Ingram, an iconic clinical colossus who has moved palliative care from the ivory towers to the small towns of America. So we are the ones that need to be moved forward to act as translators for patients. Secondly, we need to understand options. Mr. Wolf's mother was in her late 80s, had a major cardiac surgery, and now the family is wondering, was that the right decision? And equally importantly, we need to be mindful of that second elephant to be sure that the dots are connected so that we've done our financial and personal homework. Here's my email address. At a quiet moment, if you have an insight or a perspective, I would like to hear from you, because we're all in the same boat, we're all on the same starship, trying to find peace and serenity, dealing with very difficult issues.
Thank you so much. I know that Michael is grateful for your words of support and caution in,
Yes.
in entering this experience. I think it's fair to say that all of us want to know more about what you do and more about you. And so that's my role here. First of all, a linguistic detail. When you say de-escalate care, is that a little bit of the elephant in the room thing where maybe we should just say, you know, we're done. It's let them die. But we jargon up our language with things like de-escalate care, and it sometimes contributes to the idea that maybe we retain the blinders, even though we're trying to be as candid as we can.
Good point. As a professional writer, you are a magnificent wordsmith. De-escalate, wind down, focus on measures crucial for quality of life and sense of well-being. I find it astonishing. We walk into the room, patient is 90, dying from cancer of the pancreas, and has 4 medicines to lower her cholesterol. Now, I'm not the brightest bulb on the tree, but there is a disconnect there.
So it's removing extraneous treatments that don't contribute to what it is we're trying to do at
Yes.
that moment when someone is dying.
And Corey Ingram is here with us, and I think what we try to do in the palliative care community is ask the questions that nobody else asks. What's important to you? What are your values? I'm astonished that when fellows and residents present cases to us, many times they never mention the patient's occupation. We need to know that. We need to find out how a couple meet. We need to find out if the patient has a pet in the family, and we put the name of that pet in the history. May I ask, how many of us have pets in our lives? How many of us have spouses or partners? Now, when I ask the first question, the hands go up and everybody smiles.
The mic is on, yes, indeed. One other linguistic question, then I want to ask you about specific cases. I'm thrilled with what you're saying, but the sort of journalist, skeptic in me gets really scared, because when I play this out, it sounds like what you might be saying with this palliative care thing is that in this healthcare world, the greatest likelihood that I'm going to be asked about my pastor, my spouse, or my pet is when I'm already too far gone. Is that true?
No.
Please say no.
No, because that's why the palliative care train should not be the caboose, it needs to be the engine. That's clever, isn't it? I just thought about that right now. We need to move it upstream, and that's why our cardiac program is a national model where the palliative care people and the surgeons and the cardiologists, as a troika, go to the bedside and explain to the patients what this all means. Let me give you an example. On Saturday morning, I visited a gentleman who was referred here from a nearby state for a mechanical heart transplant. And he fulfilled the criteria for the implantation of a mechanical heart. And I visited with him, and on our wonderful iPads, and Mayo's technology is mind-boggling, we have Google Earth. So he came from a small town in Iowa. He had no family. He had no faith connection. So this was a recipe for a problem. So if there's not a psychosocial spiritual network, patients are somewhat disqualified from these high-tech interventions.
Really? So do you then supply that network? Do you try to create a community around such a patient with what you have here with practitioners?
Absolutely.
Can you be successful doing that?
Yes, we never fail. This is Mayo Clinic. But we try to we try to stress to that patient, okay, your options are limited. We have a mechanical heart the size of a softball. We want to share this with you. However, you need that network at home to support you if there is a problem. So bring in that prodigal son. Connect with the family you haven't seen. Without that network, the probability of a problem with your heart is 100%.
How many people have you seen die?
I have been touched by about 40,000 clinical encounters with the terminally ill.
Is end of life the same as death?
No. End of life is a process, it's an evolution, it can be tweaked. Death is a finality.
Is end of life like adolescence, toddlerness, infancy, in that it is a distinct phase of human existence that for most of us in this room, aside from you, is a relative mystery?
Absolutely. And we can look back on every patient and every one of our family members and know when that end of life journey started. That's when grandma falls and breaks her hip. That's when grandpa has an automobile accident. That's when your sister doesn't file her taxes because of a memory issue. So it's subtle, but when we look back, we can see when the train came off the tracks.
Well, in that sense, you could also just go back to birth because, you know, the end is clear once you're alive. I guess the question for me is, how do you, as a clinician, begin to see the signs that we're in a real end stage? Maybe it's 72 hours, maybe it's, I don't know how to create the sort of time envelope here, but what happens to a person as they move towards the tangible end and acquire awareness of it, if that is the case, because many people don't have awareness when they
There
die.
are two factors. There's a biological factor, and we call that fragility. People lose muscle mass, you've all experienced this. They lose that energy, they become non-ambulatory. One of the most significant factors in early death is the inability to navigate because of illness. But the other issue that we see every day is a disease of the soul. And this is called existential suffering. And if there are fences to be mended, if there are dots to be connected, and if they're not, the good death becomes very elusive.
So how are you not, if I'm in a bed here at Mayo and you show up by my bedside, how are you not the Grim Reaper of Mayo, in that I see you and I'm going, oh my God, it's really bad?
Because I'm better looking than a lot of my colleagues, for one thing.
I'll give you that.
Okay. But secondly, we offer hope, we offer options, we offer alternatives, because we're one of the first groups to say, gee, how are you doing? What's going on in your life? How can we help you? Many patients throughout the medical complex don't know who their doctor is. So we provide that service. We are the tour director, we are the travel agent, we interpret what all the other people are talking about. For example, we're all familiar with CPR, cardiopulmonary resuscitation. What most patients don't understand, the chances of being resuscitated and going home are 1 in 7. Only 15% ever make it to the door. So we can reframe options for patients so we know how to suggest what might be best for them.
Using a patient who comes to mind without disclosing any specific identity details, can you replay for me a conversation about what do you need? Well, I need this. I'd love to have this. Well, we can get that for you. We can't get you this, that sort of thing.
Sure. 2 days ago, I see a gentleman who is a farmer from a small town in North Dakota, had a bone marrow cancer called multiple myeloma. He's in the bed, serious trouble. He's on a kidney dialysis machines, antibiotics, medicines to maintain his blood pressure. His wife is to the left, 3 farmer sons to the right. And what we shared with him is that let's have the blood doctors do their thing, but if you are not getting better by your numbers, we should think about some other options and alternatives. And we're the ones to bring to the table the physical therapist, the clergy, and the other comfort measures which some of the technical specialties may not think about.
What did he say when you presented that to him?
He said, "You're the first guy to make any sense."
And what was his next question?
His next question was, when can we start? Because the technical people talked about all the mechanical things about his kidneys, all his blood values, all his protein cancer type things, but nobody stepped back to look at the big picture. He was a farmer that had 5,000 acres. I now know that this time of the year is crucial for farmers. He is having anticipatory grief because he's not in the combine taking care of the soybeans and the corn.
Did you talk to him about that?
Yes, I said, I came from New York, I thought corn came from a can. So we had that bondedness. Yeah.
So you talked about how the corn gets from his combine to your can there
Right.
in the Newark Shopping Center.
Absolutely.
Yeah. How much do you have to be able to bob and weave on your feet? Because you're not always going to encounter somebody whose life experience has any intersection with yours.
All the time. We need to be nimble because you never know where there's going to be a question out of left field. So we're visiting with Mr. Jones, and there's a woman in the room, and she says, well, how long will he live? Wow. And what we've learned is to find out who's in the room. About 2 years ago, I walked into one of our units. The gentleman had a serious problem. To my left was his ex-wife. To my right was his present wife, and behind me was his girlfriend. And I'm thinking, now what website did I not access to learn how to deal with this? So yes, we need to be nimble.
So how do you deal with it?
You first find out who is whom and what their relationship is to the patient. And then we ask the patient, gee, whom would you like to be here as we go down this road talking about options and alternatives?
And what was the outcome there? Oh, let them all stay, or kick the girlfriend out, or I only want to talk to the girlfriend?
Get rid of all of them.
For now, not
For now.
forever.
But this
yeah.
gets back into this will and trust business. A gentleman of some assets, if there's not a crystal clear will, there can be a lot of unhappiness.
Have you ever had to argue with a specialist who, for reasons that you believed to be numerically valid but humanistically invalid, wanted to conduct a procedure on a patient which you said, no, we're not doing this?
Not argue, John, but you and I are from
What's the conversation? I don't want to create conflict here.
I should share that coming from New Jersey, there are creative ways of helping people to cooperate. Right? Right.
I don't know if you want that brand, but
So what we share with the colleagues over a cup of coffee, not in the room, not in front of the patient and family, John, can you help me understand why you're suggesting a third-line kind of chemotherapy for this patient? And then I can come back with the data, knowing that if you've had, let's say, cancer of the colon, and if you have not done well with the first treatment, the chances of the second-line backup treatment working are vanishingly low. So I could constructively share the data with him, and never has this been an issue, never.
in that kind of a situation, you're dealing with a patient who has how long to live, do you think?
Most of the patients that we see would have a survival of about 5 to 7 days overall.
So why do any of it? Why do any of that stuff? In other words, when you're in that zone, why don't we just dispense with all of the measurements and really think about what it is we're going to do to maximize the quality of these last hours? How do we have that conversation?
And that's the question and the conversation we have with the patient. For example, there are data that like 30% of patients have gotten chemotherapy within the last 10 or 15 days of life. Most of us will spend the last 10 days of our lives in an intensive care unit. So the numbers are chilling. Most of us will spend the last 10 days of our life with overwhelming pain if there is not a palliative care presence. So the question we bring to the bedside, what are you most concerned about? How can we help you?
And you've mentioned that the questions can be all over the map, whether someone's a farmer or what their experience is or what their concerns are about their relative. But in terms of what it is they're concerned about for themselves and their body right there at that moment, what is the thing they most often want?
Without question, control. I want to have some say over my life. It's not pain, it's not depression in general, it's not abandonment, but I want to somehow be in charge because I'm giving up my autonomy because of all of the gadgeteers who are treating me.
So what does that control mean? Because on a certain level, it seems completely contradictory. This is a person who's facing mortality, and one would think that there's no control there at all.
One control is to make sure that patients are not awakened at 2 o'clock in the morning to give them a sleeping medicine.
So control that comes from a different kind of respect for that individual that allows them to feel maybe they're not driving things, but they're the top of the chain here in terms of decision making.
Yeah, absolutely. They are the reason why we're here. And I think we focus on this notion of patient and family-centered care, not provider-centered care. Fundamental distinction.
What was your life change that sent you down this road? Because if you're a traditionally trained physician, I can't imagine that you got much of this kind of training back at the University of Michigan.
No, but I'll tell you where I got it. 615 Hunterdon Street, Newark, New Jersey. True story, and I've shared this with in public. My grandmother came from Ireland, and by the way, we Irish saved civilization. I know there's been some confusion about that.
No, hell of a job. Thanks for that, by the way.
Thank you. And look at the mess.
Yeah.
But my grandmother owned a rooming house, and on the second floor, and this rooming house had 18 non-recovering alcoholics. And there was a Polish immigrant, and I remember his name, John Grabowski, who had cancer of the rectum. Cancer of the rectum in the 1950s was not a neat disease. And my job as a little boy was to change his appliance. I knew a light bulb went on that that's what I would do. So I was given the gift of not going down a lot of professional cul-de-sacs. I had a very clear focus, and for that, I've been eternally grateful.
So you went into medicine with the question already in your mind, how am I going to get the expertise to do better what I was given the task to do with Grabowski?
Yes,
right?
Absolutely.
And how long did it take for anyone to actually answer that question?
Most of my colleagues look upon us in palliative care as if we're from an alien spaceship until they're faced with the thorny end-of-life issues. But I became board certified in '97, and I think that's when there was a general awakening of the Mayo Foundation that palliative care is important. And with all sense of modesty, as we talked about, with Dr. Ingram and the Mayo Enterprise, we have one of the largest and deepest palliative care programs in the world.
40,000 people who you've personally witnessed or have been a part of your care.
Yeah. 40,000 clinical contacts.
Clinical contacts.
Yes.
How do you control your own emotions over something like that?
You need grace.
You need more than grace.
A defiant resilience, and you need to be dead fit, to use a racetrack term.
Dead fit. Whoa. In a sense, the kinds of experiences that you're describing are experiences where doctors are made aware that they have almost no control over the outcome.
Mm-hmm.
How emotionally invested are you in patients who you maybe don't want to see slip away, but are?
Without question, all of us go through a grieving process. And I can think of some incredibly heroic patients whose deaths were a saber in the soul, but
Give me one.
I can think of a young woman who had metastatic breast cancer, 2 wonderful children, cascaded from one experimental program to the next, and then passed away from liver failure due to cancer. Painful, painful situation, because I knew that her children would never know the love and nurturing of this woman as their mother.
Can you give me a conversation with those children?
These children were in elementary school, and
God.
what we've learned is at the bedside to ask them, what do you understand about your mom's condition? And even children as young as 6 or 7 or 8 can verbalize their acknowledgement that mom is sick, that mom is doing her best, the doctors are working hard, but sometimes things don't work out. Now, if they come from
What did those kids say to you then?
They didn't say anything. They simply looked at me and the tears welled up. It's easier if they come from a farming background where they're used to seeing the life cycle. Most of us never see anything die, then it becomes more difficult.
Is it possible in the United States to have a responsible conversation about the investments made in end-of-life care and, at the end of the day, increase the quality of the end of life? Or are we simply talking about subtracting what we do now and we'll just have to deal with the results?
Without question. By artful manipulation of tests and consultation, we can enhance quality of life, without doubt. And the data are overwhelming. That when the palliative care and hospice people are involved, there's greater patient satisfaction, there's less complex grief among the family, and it's easier for them to embrace and reconcile the death of the patient. The data are not controvertible.
So I get back to a question I asked earlier. Is the dying process that we call it, is it a rite of passage? Is it something that there is, whatever we may think about death and however it terrifies us, is there a place for everyone in the family to have a role, to say goodbye, to help with this quality of life? I mean, is it a stage of life like adolescence that we should know as much about as is written about adolescent? What's going to happen to your teenagers?
Absolutely. And those of us in the palliative care world have the skill set to somewhat anticipate when that patient will die. We're not prophets, but we can alert the family that there are signs that we see from the bedside that the end is relatively near. And what we've learned to do when the family says, gee, Uncle Joe is in Honolulu, should he come home? We've learned to say, yes, come home.
Now, how do you learn to say yes on that?
We only learn from our mistakes and misadventures. And I would bet that none of us here have ever learned from our successes, but we sure learn. And one of the things I've learned is never, ever take away hope.
What was your worst mistake? We certainly had Laura Adams convey, in very candid terms, the mistake that she made earlier in her career.
One of the mistakes was going into a patient's room at the Methodist Hospital late at night, 9, 10 o'clock. This was many years ago when I was not as enlightened, and went in through the litany of chemotherapy, all of the side effects, and then the next morning the patient says, you know, I didn't sleep a wink last night. I was devastated, I was frightened. I've never done that again.
So, have you ever had to convince someone who, for whatever reason, didn't want to believe it or wasn't articulating what was actually happening to them physiologically, believed perhaps that, you know, they were going to go to their child's musical pageant in May, but in February it was fairly clear they weren't going to make it to March? Did you ever have to tell someone, and be specific without conveying an identity?
Yes, I can think of a gentleman from the southeast part of the United States, a heavy hitter. He was a contractor. And he bid on building a marina off the southeast coast of Florida. And the deal was, if he built it within a year, everything's fine. If he went over that year, the family would absorb a debt of $1 bazillion. So we had to have a very frank conversation. He had cancer of the pancreas. And to say, Mr. So-and-so, look, we're hoping for the best, but please understand you will lose your level of fitness and you may not be able to honor that contract. And he did not sign the contract.
What was the conversation like?
The conversation was that the probability of your passing away within the next X amount of time is very high. Some people do well, but I'm doubtful that you will have the energy and the focus and the karma to bring this project in on time and under budget, and he was okay with that.
If somebody who's dying says to you, of all people, you know, Doc, I think I'm gonna make it, I feel lucky, I bet you have an answer for them.
Sure.
What is it?
The answer is, I hope you make it too. I hope that you're lucky, but let's just plan that if that hot horse doesn't come in, if you don't win American Idol, what's plan B? Let's just think about plan B.
Although in that particular case, isn't the death of that person probably plan A?
Yes, it's plan A.
What's the worst lie you ever told somebody?
I wouldn't use the word lie.
I figured you wouldn't.
How about misspeak?
Go for it.
I've had some circumstances where we've had a difficult conversation with the family, and because of fatigue, culture, education, I don't think they really absorbed what I was saying. And I think we've all recognized that under stress, most of us remember nothing. And there have been studies, God forbid, John, you have a problem, you signed an informed consent sheet for a treatment, and if I give you a test on what you signed, your recollection is basically zero. So I think what we've learned, fatigue, stress, cultural tensions, have a low profile, don't do it at night.
But it sounds like what you're saying is that you can recall an experience or a set of experiences where you communicated something and you understood based on the stress of those individuals that they weren't receiving the message, and you didn't correct it.
Right, let me give you an example. Patient had cancer of the colon. The surgeon removed it. We have some of the most skillful surgeons in the world. And there were 15 lymph nodes, which are kind of filters near the cancer. Each of the 15 were contaminated with cancer cells. So I made the point to the family, gee, the surgeons removed all of the cancer, but we need to talk about preventive treatments. All they heard, the surgeon removed the cancer, they heard nothing else. So I think we need to speak slowly, eye contact, and we have to know the socioeconomics of that patient so they know where we're coming from.
When a patient dies and there are, say, elementary school aged children left at the bedside with other family members, do you have a role as a doctor in that situation, and can you recall a conversation with somebody who was left behind?
Yes, I can recall a situation at St. Mary's Hospital. There was a woman from Southeast Asia, from Cambodia, who had died. She was extubated. The breathing tube was removed by design. 2 young girls at the bedside, and they were absolutely expressionless about the death of their mother. And all we can give is the power of presence. Not say anything. I think Woody Allen said 80% of life is just showing up. And that's what we do. We show up.
And so you stayed by the bedside as those expressionless girls looked at their dead mother?
Yes.
For how long?
Half hour, maybe 25 minutes. To leave is not good karma.
But that was a role you were playing as a caregiver at that moment, even though you were standing doing nothing.
Yes. But we're not doing nothing. We're honoring, acknowledging. We're a continuation of what we did and the present sadness.
You know, I got to feel like palliative care is something that we could use all throughout the medical experience, not simply in the last 72 hours. Would you agree
And
with
I
me?
think that's where the disconnect comes. Palliative care is the big enchilada, and hospice is only a small sliver of that. And there's clearly a movement to move palliative care up front so that we see that patient at the time of diagnosis, because we listen, other colleagues listen, but we have a finesse and a nuance with pain medications. We are the only people that talk about bowel habits. And not to get too sensitive, but if you are constipated, that's not a good day. And I can tell some of you right now are constipated. But we are the ones who focus on that, because we know if you give someone pain medicines, they will have a problem. Now, this is not gastroenterology, this is not brain surgery, but it's what we've learned to do.
Listen to the patient.
Yes.
Give them what they want.
Yeah. Where do you live? What kind of work do you do? Let me give you one story. I saw a gentleman from another state a while ago. He was in his early 90s, disheveled, unkempt, advanced cancer, serious problem. Nowhere in the record was his occupation. Mr. Smith, what kind of work did you do? He said, son, called me son, did you ever hear of J. Robert Oppenheimer? Sure. Did you ever hear of the Manhattan Project? Sure. This disheveled patient was the chief physicist that designed the atom bomb, and nobody knew it. So he was just not another CAT scan or another bone scan. He was an exciting piece of history that transformed the world.
And all it took was someone to ask to
Right.
learn it. All right.
Where are you from?
Dr. Creagan, I really appreciate your candor and willingness to spend some time answering these questions. Thank you so much.
Thank you.